Kate Ryder, thank you for coming on to talk to Zach and I.
Thanks. Excited to be here. I've heard so much about you, Logan, for years.
I know. Kate, maybe I can give my quick context, but my now fiance, Tori, who we referenced last week, is what? She's been at Maven now for 3 years. I guess she joined right around the time we started dating. So I can almost time it exactly when she joined. And then we lived in your house at the very beginning of the pandemic, which is a weird to meet over a video podcast right now. When I lived in your house in the middle of the pandemic, so but I appreciate you doing this. I'm glad everyone got to see live our actual meet and greet here.
Yeah, no, totally. It was I remember that. Yeah, we left in a rush. I think it was like March 12th, 2020, and then you and Tori moved in I think a day later because you were like, there could be looting. We don't know what's going to happen. Do you want to just live in this house? You would be doing us a favor, and it was awesome that you guys did that.
It worked out. It's a wonderful place. I know exactly where you're recording. I think that was my office in the middle of the pandemic for about 3 weeks or so. And this was I guess middle of March, end of March 2020, so kind of a bleak period in the world. And so it's a wonderful home, and I am very thankful that you allowed us to do that. But yeah, not my kind of a weird memories associated with sitting there and working on that exact table you're sitting at now.
And would you have ever thought that 2.5 years later, you'd be engaged to Tori and we'd be doing this podcast? You hadn't started this podcast, right?
I know. You know, as a young boy, I aspired to have a podcast, and you know, I think every white man named Logan's dream is like to have a podcast one day, and so thankfully, yeah, it came to fruition for me, and then actually, funny enough, Zach and I, we had only met over video, and we actually met last week in person. And he told me I gave off much shorter energy over video, and I'm far taller than he expected in person. So yeah, that was an interesting kind of like backhanded insult. I wasn't exactly sure how to take that.
I just assumed you were like a tiny little man with big internet opinions. And it turns out you're actually extraordinarily tall and you still have big internet opinions, actually. So my assumptions were all wrong.
Yeah, exactly. No, it's an interesting. I mean, we had a fun time on Thursday night. Zach, hopefully you enjoyed yourself. Our first. I'm sorry we weren't able to actually get video footage of it. I think that's something we probably could have NFT'd out or something. Us actually meeting for the first time.
Probably for the best after us having like a few drinks together. I don't think we want to be recording ourselves at that point.
I think that's probably right. I think about the time Aaron Levy walked in and you said, "Oh, it's the big Jew himself." I think that was probably no longer do we want any recording footage of what transpired after that.
I'm glad you remember that moment because until 2 minutes ago, I didn't.
Yeah, no, that was a notable moment in my. I don't think Levy knew exactly how to respond to that. But well, Kate, thank you for doing this. And I guess you guys know each other through just Healthcare New York. Is that right?
Yes, and Zach gave one of the best lunch and learns to our company right before COVID hit. So it was one of the last in-person lunch and learns in 2019, which was great. So good to be together again, Zach.
I remember clearly. I remember talking to the team. You had a bunch of people ask very good questions. And then I left. And I remember thinking on my way back, I think it's probably going to the Flatiron offices. Why did I not ask to invest? I can't remember exactly what was going through my head. I might have been distracted, but that was definitely a regret of mine, not walking out of the room without some allocation in your last or next round. So my bad on that.
Well, you can't get them all, Zach. You've had a good run, so it's nice. Whatever angels actually snuck their way into that, it's nice for you to save some for the rest of us. But maybe Kate, just about lead off and give people kind of an overview. Can you give us the quick version of your foray into being the founder CEO of Maven, and then a little bit about what Maven actually does?
Sure. So I always knew I wanted to start a company right at the time when I realized that journalism wasn't going to be my long-term career. I was living in Singapore and tried to start my first business off the back of one of the stories I was writing actually about the Chinese travel industry. So although that never took off, it definitely made me really excited to one day kind of do it. And my dad, who was an entrepreneur, he gave me a piece of advice at the time, which was, that this sounds like an interesting idea, and I think you'd be a good entrepreneur, but go learn on somebody else's dime first. And so I got a job in venture capital. My husband and I ended up moving to London. I got a job in venture capital, worked in London for 2 years, and then launched Maven off the back of that. So it was a kind of winding path, and there was lots of learning along the way, and particularly in the 2 years of venture capital, but really obviously excited where we ended up. And one of the best pieces of advice I got at Index was start something that you're passionate about, and that you're, if you're still doing this job in 10 to 15 to 20 years, that you still care about the problem. And so women's and family health, I still care about that problem, and unfortunately it's getting worse, not better.
So maybe tell us a little bit, you alluded to it there, but what does Maven do today? Where did it start at? What was the insight you had back then? And then what are you up to today?
Sure. So Maven is the largest virtual clinic in women's and family health. And so we have a virtual care platform that starts with preconception care and goes through menopause now. We just launched that this year. And the core insight, 8 years ago when I started was, the digital health industry was kind of at the end of the first inning. And there's some interesting companies, particularly in primary care and telemedicine and tracking. And there's this common theme that, that women were the dominant consumer, and that they were all trying to crack digital patient engagement. And one of the, it was right around the time that my best friend had a child. She was the first of our friend group to have a kid. And her experience, and then the subsequent experiences of my friends, and then my own experiences, I have 3 kids today. It was just eye-opening how women were really at the center of the healthcare system. And yet this one moment at the beginning of a family and growing a family was so massively underserved. There's a huge business case to be made for it. And so, I thought, wow, this is something, if changing this is something that takes me 10 to 15 to 20 years. But we really can do something here and shape the entire healthcare industry to be a little bit more designed for women and families. That would be an amazing opportunity. And so 8 years later, we're still at it.
You mentioned digital patient engagement or digital engagement broadly. Can you define that? Because I always hear that term tossed around, and I think it's used differently by different people. So how do you think about it, and how might that differ from just going and seeing your regular doctor or OB in this case?
Sure. So the way we think about it today is we have a digital experience in the various programs that we have. And so we look at both touch points. So that's, how many times, and we have different touch points. So how many times somebody's opening the app to, the content reads, the virtual classes they go to, the varying levels of engagement with our community and content products. Then all the way into how many times are they engaging with their care advocate and their navigator, all the way up to and how many times they're actually using a telemedicine, booking appointments with providers. So we kind of have a hierarchy of digital engagement. I think at the time, though, 8 years ago, it was just like trying to get people to engage, period. And still today, I think you're right. A lot of the companies define engagement differently. We define it like a consumer app because we're a B2B2C product. And so the only way we're going to be successful is people are using us like they would use any consumer product.
Kate, so originally you started, though, consumer facing. Was the ultimate As I understand it today, because I could probably give your sales pitch, having lived with someone for 2 years that has been an employee. So I guess as I think about it, which I think I have a pretty good understanding, but you started originally consumer facing and then went B2B and then employer. Was that like a purposeful insight that consumer is where to start with all of this, or was that like an evolution of trying to understand the distribution methods of how to actually serve these people, ultimately employers and therefore payers, was like the way to actually go about doing it?
Yeah, sure. Good question. So now there's a term for it. I didn't really know the term when we were doing it, but I guess it's called B2C2B, go to market in healthcare. And the rationale in plain speak at the time was, if the best way we're able to drive real clinical outcomes and prove that our care model is the better care model for patients than what they have today, then we have to have the best consumer product. And so let's go kind of learn and try out the consumer market. They're in some ways they're the biggest critics. Any consumer, if they're not liking something, they're going to put the product down. And then also because at the time this was 2014, 2015, 2016, a lot of investors didn't, weren't really, they didn't really understand digital health yet. And so we also had to show momentum in a way that, selling to employers just took a longer time. And so I definitely leaned heavily on some other digital health founders and friends who were taking the same route at the time. So TJ Parker from PillPack is one of them, where they built a consumer product, but then they had to go get those pharmacy licenses in all the various states. And then, and then they were starting to sell through the B2B channels. But, Sean Duffy at Omada, very, very similar. So it ultimately proved to be the right go-to-market. I just think I did not know it was going to take so long. And I think, and so, now in hindsight, we're lucky that we spent those years building a great product, because now when the scale came, we were ready for it. But, the first few years were a total grind.
And so the initial product that you launched with, was it like a doctor navigation tool for consumers? Was that what was like the original wedge that you got in with to actually get people using the product?
So the original thesis was all about access. So so much of what I observed in my friends and then my own experiences was, we were such uneducated consumers going into these big moments of, starting families, getting pregnant, going through IVF. And so we needed to meet way more types of providers who could support us. So there was mental health, nutrition, women's health, physical therapy, doulas, midwives. I mean, there are so many amazing providers in women's and family health that are not part of traditional reimbursement models. So one, it was, how do we provide access to all of those different types of providers and build this kind of holistic care team? And then two is, how do we do it in a way that's more modern than, waiting 3 weeks to go to the doctor? And so that was the on-demand telemedicine component. And so, that was the core insight. It wasn't necessarily async at that point. And we knew we had to go B2B. We were actually pitching our first B2B product, which was a maternity product, even before we launched the consumer product. But it was always very much about the care model itself. And how do you use technology to actually improve the underlying care model?
How did you think about, in terms of the content and then actually the clinical staff, that the patients would, I always think patient, but that the members would ultimately get access to, and how that relates to their primary care doc or their OB, and the interaction of, the questions they're asking and the actual doctor they're seeing in person?
Yeah. So the reality is, when a lot of women get pregnant for the first time or go through IVF, they don't have an OB or a clinic. So we see that today in our data, but just kind of from, just a lot of conversations. It was very clear with my own personal experience as well. And then when you're going to an OB, sometimes you're seeing somebody, other times you're just in a practice. So you're not actually building those enduring relationships. And I think also that the in-person patient experience is you're only going once a month, and you might have 10 minutes with the doctor. And so so much of IVF for pregnancy happens outside of those 10 minutes. And whether it's, nutrition support, or you're managing a high risk condition, or mental health, or just kind of career coaching, which is one of our more popular provider types, all of that are ways in which people are using Maven outside. And then we're complementing that in-person experience. And then postpartum, there was nothing. So that was also one of the core insights when we launched was, everything stops right after the baby is born. There's no paid leave. At that time, like a lot of people didn't have leave. There were no return to work programs. No health plan programs went beyond 9 months. None of the apps did. And so it was kind of like we complemented that in-person care model during the 9 months of pregnancy. And then when postpartum hit, we actually were the primary provider because there was nothing else.
So the whole idea was to make sure that you were almost by design, in a sense, like complementary to the very specific but narrow, I guess, medical care you would see from an OB, where you have to be physically present and focus on all the kind of like supportive care and access challenges for, in a sense, everything else. Is that like a fair way of thinking about it?
Yeah, I would say there's a core prenatal model today. And that's this kind of, you go to the doctor once a month and you may know them well, you may not, and then you deliver in a hospital. And ours was, there's so many gaps around that core model. And then postpartum is like a large gap. Return to work, 43% of new moms don't return to the workplace after having kids. That's a large gap that's not supported. And then even before that, we launched our fertility product in 2017. The whole, IVF, egg freezing, surrogacy, adoption pathways were also not part of the traditional model. So there was not just the complement to the 9 months of pregnancy, but it was all of the things around that to really equalize the care.
Can I actually ask what you guys living healthcare? Probably, it's probably intuitive to this, but like I have health insurance through, a payer, right? There's someone that provides me health insurance through Redpoint as an employer. Why is this, like, all of these things, and what are all of these things that, and we've touched on it throughout the discussion, but what are all these things that are like above and beyond what I would actually get from my provider of health insurance through Redpoint? Like, why does this, and I know there's other businesses that have done well, Livongo acquired for whatever, tens of billions of dollars. And then there's Hinge Health, and there's a bunch of other benefit companies that have popped up. But like, why are these incremental things that exist at all? And I guess, why is women's health a unique one specifically, Kate?
I mean, in an ideal world, none of these benefits would exist because your core health provider would cover it all. And so, I think we don't live in an ideal world, which is why there's such a large and growing digital health industry. I think for our market specifically, what's really different and why we started with building the largest women's and family health telemedicine network is the wedge into the consumer experience is with primary care, with chronic disease management, with mental health. A lot of that is getting patients to the right provider and helping them understand, that match and giving them that high quality care. And often making it tech enabled and, that's more convenient and whatnot. But with us and with women's and family health, there's just parts of it that are not in the healthcare system in the first place. And so fertility is a perfect example of that. I would hope that maybe you now have fertility benefits through Redpoint, but a lot of the health plans don't cover it and haven't covered it. It's a huge driver in sales in the market. And then with maternity benefits, what's happening is a lot of companies see maternity as their top cost when it comes to healthcare spend. So if you think about a big Fortune 50 employer, like 10 to 12% of their entire healthcare budget, which could be billions of dollars, is spent on maternity care. And then they have this big problem where a lot of women are not coming back to work afterwards. And they look at their maternity spend and, there could be high rates of NICU spend or high C-section rates. And so that's an area where they want to better clinically manage it. And they also want to, really help women transition back to work and be able to breastfeed when they go back to work. So again, there's like major gaps right there. And then moving into what COVID really exposed was how burnt out parents are and how managing your kids' health as a parent while managing your career is also just added stress and continuation of the journey. And so we also have a parenting and pediatrics product. And then menopause, which we just launched this year, that was similar to fertility. There was just like nothing there, period. And employees have started to ask about it. And as a lot of these benefits leaders look for, equitable benefits, and DEI is really important to them, you kind of have to invest in these areas. So very similar to like the Hinges or the others, in that there's a major medical spend category here where they're trying to control costs, but different a little bit where this is a huge DEI benefit in a way that maybe some of the other medical benefits are not.
And maybe for like a little history, and then Kate, I'd love to get your take on this. If you think of the way healthcare has been paid for, most healthcare is reimbursed by an insurance company. We don't have to go into who pays for the actual underlying insurance, but it's meant to reimburse for medical care, right? Like it was designed around providing care by doctors, kind of the easiest way to think about this, for a very specific set of work that they would do. And in many cases, it's not like perfectly this way, but based on the amount of time that it would take and the complexity of what that doctor was doing. And you get these situations in healthcare where not everything is about the like specific medical care that the doctor is providing. There's like supportive care benefits actually in women's health. This is probably one of the biggest areas where it's not just about, the physical exam or the diagnostic procedure. There's like plenty of stuff around it, but our healthcare system was not really designed to pay for that stuff. And so you see employers having to pony up money for like extra benefits that the typical insurance plan just simply doesn't cover. And then you kind of combine it. And okay, this is, I'm curious what your take on this, but the history of designing who gets paid for what and what's paid for by insurance is kind of negotiated by a panel of doctors with Medicare. And then it kind of like trickles down from there with the commercial insurance companies. And most of those doctors are basically like old white guys. And so you've seen like significant under reimbursement for women's health because the people sitting in the dark room deciding on what is covered and what isn't, and what's medical care and what isn't medical care are basically just like old men. And we're paying for that now downstream. At least that's been my impression. I'm not like super in the weeds on the exact codes.
Yeah, I mean, listen, I think there was a very famous picture during the last administration where everyone's talking about maternity benefits. And there was this big, debate like, oh my gosh, why should the average taxpayer have to pay for maternity benefits? And it was a room full of men and there was not a single woman in that room. And it was basically saying like, only women should pay more for their health insurance and healthcare because they're the ones having the babies. And so I think, that point of view has certainly led to, I think, major underfunded areas and just enormous gaps in care. And I think we see it in the statistics. The United States has the worst maternal death rate among all peer nations and in the developed world. And that's actually increased during COVID by 21%, which is pretty horrifying. And when you look at C-section rates compared to, what the World Health Organization would recommend in a country, like the US, like we're 20 percentage points above that. When you look at just all of these stats compared against many, many other countries, I mean, we're just consistently last.
Hey, Kate, and so maybe like a specific one on that, because you bring it up and it's interesting to me. So like, as I understand it, at a very literal level, like there's these outcome related services that maybe my health insurance covers, right? And so one of those could be like pregnancy. But there's a lot of things that exist outside of pregnancy that could be preventative or educational or supportive from a benefit standpoint that would be helpful that's not actually the childbirth. And so I guess one, is that right? And two, you use the example of C-sections, which I think is an interesting one. And I would love for you to drill down on that, because as I understand it, C-sections are very easy for the doctor and very hard for the woman. And basically, because of how the incentives are structured, the doctors, we disproportionately lean on C-sections in our country because the doctors, it's predictable. They can get back out of the surgery room exactly when they want to, versus the randomness associated with a non-C-section childbirth, right? Can you touch on those two things just to expand on that point?
Yeah, I would think of it as like, what is the most surprising and yet important thing that insurance typically doesn't cover that you help with?
So I would say that the most surprising thing about what insurance doesn't cover is pretty much everything outside of your core OB visits. So whereas, the technology in the labor and delivery rooms has gotten better and better, it's certainly much better than it was 100 years ago. There's just really obvious things like the way that that presence of a doula can reduce the C-section rate. And so at a population level, it would make sense to reimburse doulas. And you're starting to see some of that across the states. But, that whole concept was just, even though the economics and the numbers just proved how important that would be, just not there. I think mental health, we still have a long way to go. 1 out of 5 women suffer from some kind of perinatal mental health issue. That's also not baked into reimbursement models and can lead to, worse outcomes. And so, things like this, like for instance, breastfeeding, higher breastfeeding rates is linked to lower rates of heart disease in women. That's a little bit longer term than just the short term, but heart disease is one of the top killers of women. And so you would think that just little tweaks to the model would from a population level really actually drive better outcomes and reduce costs. And so none of that was being taken into consideration. And then even areas like miscarriage, 1 out of 4 or 1 out of 5 pregnancies end in miscarriage, and there's just nothing there. And so those are some examples of just, fertility aside, even in the core pregnancy episode, there's just so much that's not covered. Women's health, physical therapy as well, pelvic floor. And then when it comes to C-sections, you look at some of the incentives then that as women are going through this experience, and now they're in the healthcare system where there's, tons of misaligned incentives. The childbirth is the number 1 reason for hospitalization in the U.S. Lots of money is made on childbirth. And so there are things sometimes in hospitals where on the labor and delivery floor, they might have a rule where a woman can only labor for 8 hours and then they have to do the C-section because it's heads in beds, or, or it could be the doctor's choice. And the doctor's just trying to kind of get through a certain number of patients that day because they're paid more when they do the C-section versus just kind of a vaginal birth. And, there are great doctors out there, and there are great hospitals out there, but there's also, not great doctors out there. And there are also rules in some of these hospitals that are to minimize medical malpractice versus do what's best for the patient. And so, all of this is what, as a woman is going through, and a family too, a couple really, is going through this very vulnerable experience where it's not just your own health, but it's the health of the baby that you're bringing into the world. Everything is just so cosmic all the time and so existential. And so to think that you're going through this big experience in a system that's actually not designed for you and sometimes is designed in ways that are not helping you, I think you just need such an advocate, and Maven is that advocate to help you through all of these decisions that you have to make.
From an economic model standpoint, so you sell through to an employer. So the employer says, I have a employee population of X number of people. Some percentage of that are women. Some percentage of that are women who are likely to give birth in the next, however many years. So this is like a target population is important to me. But unfortunately, my current insurance plan, of which as the employer, I'm paying the premium or some percentage of the premium, it's just not covered. So you come in and fill that gap. How do they pay for it? You don't have to give away the exact pricing, but like, how did you think about charging and pricing the benefit there, given it's on top of insurance that the employer is already at least contributing towards?
So we fit really nicely into the model of what a lot of chronic condition companies do and disease management companies, which is, there are a certain number of pregnancies per year or a certain number of IVF journeys or, surrogacy journeys. And so we just charge based on who utilizes the program. And so what the employer is looking at is the spend affiliated with fertility, which is, a lot of employers right now are starting to cover fertility, period. And the average cost of an IVF cycle these days is almost $25,000. So a lot of employers are freaking out at the cost. 1 out of 8 couples, is infertile, and other, 20% of millennials are in LGBTQ relationships. So they're like, wow, these could be really big numbers here. So that's number one. And then, that leads into pregnancy, and pregnancy that's high risk that can be, lead to complications. You could have, $500,000, $1 million babies that are really driving up your medical spend. And so what employers are looking at is beyond just member experience. How do we take an area that could be, millions, tens of millions, hundreds of millions of dollars, depending on their scale, and how do we put in a program that's going to help our patients and give them the best member experience, but also help us control our costs, and in the case of fertility, maximize the dollars that we're spending. Because in the fertility market, you don't want your people going through 3, 4, 5 IVF cycles. Ideally, it's only 1 because it works on the first try. And so they're thinking about that, and then they're thinking about just overall maternity costs, because more IVF leads to higher risk pregnancies.
Do you give them them being the employer, any sort of calculator, savings model? Like, how much of this is I actually go into the weeds and model the data? Because at the end of the day, it's a financial decision. And how much of this is, I want to be a good employer for women, and this is a benefit I'm willing to pay kind of above and beyond, even if it isn't necessarily savings at the end of the day. It's actually, net dollars out.
Oh, no, it's all modeling. So I think, if you're a really small company, you're doing this for talent attraction and retention. So you're probably not going to model out as much. But no. When you get into most, 5,000 employees or more, you're modeling out the savings. And we have our ROI calculators and all of that.
I figured that was the answer. That's the thing that's always the most interesting to me, is we talk a lot about the gaps in care and more from like a medical and outcome standpoint, like what we would want people to have. But actually, at the end of the day, you end up having to prove there's real financial savings, even if that gap is material and kind of like ethically an issue. It still comes down to a financial decision by, I assume, the benefits group and the CFO, who's typically making the call.
Yeah, it's usually benefits. And, I think that what has been really cool to see is some of these benefits leaders, if you think about it, like a lot of them are women, and they're looking at this not just for cost savings. So it's not like, oh my gosh, I'm going to, remember that's some of the highlights of my career, putting in that awesome musculoskeletal benefit, like really important, obviously, but like not like, wow, I'm going to remember this forever. This is like, I am improving society. I am doing something that I wish I had access to. I look at these undersupported moms around the office, or these, the LGBTQ community that's just been left out of all of these care models, and I'm going to fix that. And so that's super cool. And I think what makes Maven almost, it's a double bottom line. It's truly, not only is it attacking spend and driving better clinical outcomes, but it truly is changing things in the way that our system and our government is not.
This is kind of a probing question, but if it didn't save money and it actually cost money to provide kind of this extra benefit, do you think people would still buy it? And how, like, at what price, how much would this have to be a premium on top before people would like seriously hesitate?
Well, I think if that was the case, you would just be limited to the employer market that is really competing for talent. I think with us, I mean, we have so much growth through payers, and it's the payers that are the real unlock and open up, the entire employer market, and then they have fully insured and they have Medicaid. And so, we can work in all of those markets because of this. And I think I think there's a bunch of companies out there. It's probably an answer to your question where, they can maybe sell into Fortune 100s that are really competitive on talent, and then, small tech companies or whatnot, but they don't really grow beyond that.
Kate, I guess at a personal level, so you started this company when you were married but no kids, is that right?
Correct.
And now you have 3. How has that informed, you've been a user of the product and through 3 different pregnancies and after. How has that informed product design or decisions? And can you just talk a little bit about what it's like to actually have lived the product 3 times through?
Yeah, and more. I mean, I actually started, I had a miscarriage before I even had a viable pregnancy. So that was my first experience, and very kind of unexpected accidental pregnancy and then a miscarriage. And so, that's an example where we were the first product to have miscarriage as part of our core prenatal care model. And I think it's something that our team and certainly some of our clients really love. I remember actually one of the first clients, staff that we signed up in 2016 or 2017 had a member of their benefits team going through a miscarriage, and they wanted to launch us early. And we were like, we actually have a product for that, which is very cool. But yeah, I think I have, each pregnancy has been really different. And I truly believe that it's so important to live the experiences. It's made me a better founder. There's still so much I don't know on so many different of our pathways that I rely on tons of interviews with people who have gone through it. We're doing tons of Medicaid roundtables at the moment to understand the Medicaid experience while being pregnant. But just thinking about specific product features, the whole, I think actually one thing that it really did, I've had to have some real grit to get this business off the ground. I mean, we almost failed multiple times in the beginning. I think because I was using my own product and I knew that it was helping me a lot. I mean, particularly even through the miscarriage, I talked to 6 different providers on Maven to process it because they give you no information in the system, and kind of worked it through there. And then for my first pregnancy, I mean, I think all first-time moms are freaked out about everything. But the third is totally fine. But anyways, I was going through it and having things happen to me, like getting carpal tunnel syndrome, which is like your hands and arms are tingly, and getting a sciatica where it's hard to walk. And going to my doctor and getting nothing. And she's an amazing doctor. She's like, I don't know who to refer you to because I don't know who's in your network. And then finding I had no physical therapists in my network to help, or the toughness of going back to work, the toughness of breastfeeding that first time. I mean, as I was using it, it was just validating everything that we were building and giving us more resolve to just keep going, because I think, there was always the capital needs and would be able to kind of extend the runway until this business really took off. But I think we always knew, and I always knew we were solving something that no one else was doing. And it was really, really important and helpful. And, finally, thank God it took off.
It's interesting. One of the things I wanted to ask you about, kind of related to all of that. So you've been on both sides of this table, right? You were on the fundraising side, and then you were fundraising. I'm curious. You saw some of the tricks of how VCs operate, right? How did that? I guess what's it been like to be on both sides of the table, and where did you have more empathy from trying to understand the fundraising process as a founder that had previously been a VC? Was that able to augment, how to run a process or some of the advisors that you brought in or anything like that to make it easier? It sounds like maybe not, given you said there was a few failures along the way and having to get through it, but interested in how that informed things for you.
I actually think it didn't prepare me as much as I would have thought. I understood term sheets and I had an incredible network coming out of Index, and a lot of some of the partners there and a lot of the entrepreneurs in their network invested in Maven. I was always super tight with Rich Lee, their amazing lawyer, who was, helping in the early days on terms. So I understood that part. But what I didn't understand was when you are running a process, you need to drive a process, and it needs to be that you need to elicit some kind of FOMO, particularly in the early rounds. I mean, now it's kind of nice because it's like, hey, here are numbers. But in the Series A or the Series B, I mean, it was. I think the mistake I made in the seed and then the A, and it was a founder friend took me aside and was like, "This is what a process looks like." And he was like, "You do this, and then you do this, and you talk to this person, and you never reveal your cards." And it's actually the opposite of operating. Like when you're operating, you're trying to move fast, be transparent, get to a quick decision. And fundraising, it's like a little dance that you're doing, and investors are trying to sniff all the time. Is this a competitive deal? And and I get it. They're operating with very little information, but particularly at the A or the B. But it was I switched how I did things, and I got some real coaching for the Series B, and that was the round where we had signed some big deals at that point, so we did have Series A was just pure vision, but the Series B was we had some great early traction, but it was still vision, and I understood at that point how to run a process. So we did get multiple term sheets versus, in previous rounds it was rough. So that was definitely, I couldn't believe it, that the entrepreneurs in the background before they were showing up at the partner meetings of the fund I worked at, they were just wheeling and dealing with all of these investors. And it's not just a game to get a term sheet, but it's a game around, what the valuation's going to be.
Yeah. Well, I'm sorry you got stuck with such tier 2 funds like Sequoia and that Series B. So it feels like you ended up doing okay, all things considered. It's interesting. I mean, I actually think people now, you were going through that in 2018, right? I almost think today, or at least over the last 2 years, it almost got like a little too contrived, and the lack of authenticity. Like all the lessons that founder taught you, I think they probably posted them on some forum somewhere, because everyone learned all the same lessons of like trying to create FOMO and all of that. And it led to like this transactional lack of like, authenticity at times when people took it to its furthest extreme of like trying to build this momentum and all of that. And so I actually saw it go the other way of just like almost too much of that element of like prescriptive fundraising. So
the market crashed. So there we go.
Yeah, exactly. And then the market crashed. That's exactly right.
Yeah, I was going to ask, like, what's your take on this market in particular in terms of like previous valuation expectations and multiples that people were paying relative to where you think it's going? And this market primarily being defined as like employer benefit as opposed to more niche and kind of like direct competitors, but the broader employee benefit market.
Yeah, I think about it less as like who your buyer is, because it could be payers, whatever. And I think it feels to me it's more about are you just a healthcare services business with a little bit of tech enablement, or are you a true technology company? And I think if you're a true technology company operating within healthcare, you can get a lot more scale, leverage, margin, true innovation when it comes to delivery, care model, and all of that. And I just don't think that the first wave of companies that IPO'd really were true tech companies or are true tech companies. I think that when COVID hit, you saw a bunch of, there's such a stickiness in this industry that once you sign some of these big deals, like it's pretty hard to kick you out. There's inertia, there's a million competing priorities. But I think when COVID hit and then some of these companies, made even further strides, they were never scaling in a way that, their underlying unit economics were just getting better and better over time. And I also think that they just they weren't able to be as nimble and personalized, I think, as a lot of the tech should be to really drive that engagement and outcomes as they could have been. And so anyway, so I think that I'm excited for the next wave of digital health companies to go public, and Maven, will probably be in that pack. And it's kind of, really showing the market, actually, those companies, they did a lot of great work. They paved the way, but they weren't necessarily the companies that are going to be the enduring ones.
I want to ask just kind of a question that I think is very unique to your business, in that there's been a handful of like lightning rod societal events that have sort of occurred during your tenure running Maven. I guess most notably Roe v. Wade being overturned at the Supreme Court. And I can imagine there's elements of that are drawing a ton of attention to women's health and benefits like this, right? At the same time, I'm sure it's also traumatizing to a large portion of your members as well as employees, right? And so it's kind of this unusual thing where I can imagine this is driving, in some ways, tailwinds for the business and the need for a service like yours, or the attention paid to a service like yours. On the other, it's like this major societal event that a lot of people view as like one of the worst travesties to happen in the United States over the course of the last, 30 years, right? And so as a leader kind of going through that, can you just talk, I feel like it's so unique to your business, and you're so like maybe the only one that can really weigh in on something like this. How has it been to lead in that environment?
Yeah, I mean, listen, I think it's been harder to lead at other times that are to me, this is very black and white, and that's helped. I mean, to me, abortion is healthcare. It always has been. It's one of the top surgeries that women get in women's health, period. It is, like 1 out of 5 women will have an abortion by the time they're 45. So it's just part of healthcare, and sometimes it's a personal decision why people have one. Sometimes it's a medical decision that's privately made between a doctor and a patient. And so leading through this has been simply, I think, ensuring that we have a clarity of thought and a message, and the message is really simple, and it's that. And I think now, as we look to continue to lead through it, I think it's really important to bring a lot of the data to the light around what this is going to do to maternal health outcomes. Like, for instance, in a lot of these states with all these trigger laws, they already have, 2x more maternal deaths than states without the trigger laws. So you see a lot of these adverse outcomes, and it's only going to increase. But I think the thing that also is really interesting, and the economics has been divorced almost from these policies, because, we just saw, for instance, in a southern state, they woke up and they're like, oh my God, we're going to have 3,000 more high-risk pregnancies next year. We already can barely pay for the pregnancies we have. How on earth are we going to pay for this? And they're asking the federal government for money. And so I think that, it's just the beginning. I know that SB8 has been in place in Texas for, a while now, and the first SB8 babies have been born. And so they've been able to trace some of the outcomes. They've been looking at hospital level data on those families and those moms. And
Kate, SB8, can you elaborate on that just for people that don't know?
Sure. That was a law in Texas that went into effect that limited abortion to 6 weeks in the fall, in September of 2021. And that was kind of the case that everybody kind of, that was the writing on the wall for Roe v. Wade. It's really sad. A lot of the maternal morbidity, which is the, short and long-term complications that come with pregnancy, it's all preventable. And, a lot of them had just way more adverse outcomes, hysterectomies, just really long-term health complications for all of these women because they couldn't get the abortion. And there's also a lot of, in the provider community themselves, because the laws are so, in some of the bounty states, so punitive. And, they're saying in some states, providers can go to prison. The providers don't know how to treat women with miscarriage, women with, that really need that support. I mean, I personally, having had a miscarriage, cannot imagine going into the hospital and having people be afraid of me. And that's what's happening in all of these states. And when I really, really needed the care and I didn't know what was happening. So I just think, and by the way, the other piece of data there that's just horrific is that already 50% of US counties don't have an OBGYN. So they're called maternity care deserts. And it's in a lot of these counties where a lot of these more draconian laws are being put in place. And so, provider shortages are expected there as well. So in the states that, New York, California, where you can get full women's health care, it can be fine. But really, it's terrible what's going to happen to so many women in all of these different states that restrict this access.
It's almost like we really haven't seen how bad this is going to get, right? It's super early in the cycle.
It's very early. And so I think going back to your question of leadership, it's such a shame that it's so politicized, because this is, again, just healthcare. It's healthcare, core women's healthcare. And so I think it's just continuing to lead with data, because the data does, presents a very, very bleak and dark picture across all fronts, women's rights, economics, clinical impacts, society, children's health. It's all bad.
Yeah. It's sobering. Anything else on your side, Kate? This is fantastic. I really appreciate you bearing with our questions here and internet connectivity issues. Zach, anything on your side?
No, this is great. I think it's always interesting to see both the financial realities of, like, how do you build a business and how do you position value for the customer, but in a healthcare setting where it's not, at least in terms of, I think many people's outside perspectives, it's not just about the economics, but you have to actually be able to do both. You have to kind of win on the better care and win on the economics to be able to build like a venture scale business. And that's what's going on here. So it's pretty cool to see.
Yeah, thanks.